Hello everyone! I hope everyone is ready for today. So my name is Galarino and my group will be reporting on RLE Module 6F, determining TBSA and fluid replacement computation, peritoneal dialysis, hemodialysis, ABG analysis, and cystoclysis. So, our CLOs for today. CLO number 1 is to define the following key terms related to determining TBSA and fluid computation, peritoneal dialysis and hemodialysis, ABG analysis, and cystoclysis. CLO number 2 is to state the importance of determining TBSA. CLO number 3 is to discuss the concepts involved in determining TBSA and fluid, peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cytoclysis. CLO number 4 is to distinguish the indications and contraindications of peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cytoclysis. CLO number 5 is to explain the principles applicable to peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cytoclysis. So CLO number 6 is to examine evidence-based nursing responsibilities and guidelines in performing peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cytoclysis. CLO number 7 is to enumerate the nursing responsibilities in peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cytoclysis. CLO number 8 is to demonstrate beginning skills in hemodialysis and irrigating. And lastly, CLO number 9 is to integrate the knowledge learned on determining TBSA and fluid replacement computation, peritoneal hemodialysis, ABG analysis, irrigating cytoclysis, and providing care to a client using a clinical case scenario. Okay, let's go!
Good morning. This is NCM 112 RLE 6F, determining TBSA and fluid replacement computation, peritoneal dialysis, hemodialysis, ABG analysis, and cystoclysis. I am Nabana Eunice Patsy and I will present to you CLO number 1. Define the following key terms related to determining TBSA and fluid computation, peritoneal dialysis and hemodialysis, ABG analysis, and cystoclysis. So for the first part is autograft. It is a graft derived from one part of a patient's body and used on another part of that same patient's body. It is often thought of as the gold standard in bone grafting because of its reliability. Its high success rate is due to the fact that it is living tissue and thus its cells are kept intact. Next is collagen. It is a protein present in skin, tendon, bone, cartilage, and connective tissues. Contracture. Shrinkage of burn scar through collagen maturation. The skin becomes scarred and non-elastic, which limits the range of movement of the affected area. Cultured epithelial autograft. So these grafts provide a permanent skin replacement for patients with deep dermal or full-thickness burns. Debridement. Removal of a foreign material and devitalized tissue until surrounding healthy tissue is exposed. Removal may be surgical, mechanical, chemical, autolytic, or self-digestion, and by maggot therapy. Donor site. The area from which skin is taken to provide a skin graft from another part of the body. The common areas for donor sites are the thigh and upper arm, but it could be the back, buttocks, or abdomen. Eschar is a devitalized tissue resulting from a burn or wound. You may see eschar after a burn injury, gangrenous ulcer, fungal infection, necrotizing fasciitis, spotted fevers, and exposure to cutaneous anthrax. Heterograft, a type of tissue graft in which the donor and recipient are of different species. Heterograft skin became popular because of the limited availability and high expense of human skin tissue. Wound coverage using heterograft is a temporary covering used until autograft. Homograft, a graft transferred from one human, living or cadaveric, to another human. also called as alloga. Hydrotherapy is the use of water, hot, cold, steam, or ice to relieve discomfort and promote physical well-being. Hydrotherapy differs from swimming because it involves special exercises that you do in a warm water pool. Prosthetic, an artificial replacement of a part of the body such as tooth, a facial bone, the palate, or a joint. Rule of nines. The rule of nines assign a percentage that's either 9 or a multiple of 9 to determine how much body surface is damaged. As you can see in the picture, the front and back of the head and neck equal 9% of the body surface. The front and back of each arm and hand equal 9% of the body surface. The chest equals 9% and the stomach equals 9% of the body surface. The upper back equals 9% and the lower back equals 9% of the body surface. The front and back of each leg and foot equals 18% of the body surface and the genital area equals 1% of the body surface. Next is the arteriovenous fistula. It's an abnormal connection between an artery and a vein in which blood flows directly from an artery into a vein, bypassing some capillaries. Next, we have arteriovenous shunt, are abnormal connections between coronary arteries and a compartment of the venous side of the heart. Dialysis is a procedure to remove waste products and excess fluid from the blood when the kidneys stop working properly. Dialysate, also called as dialysis fluid, dialysis solution, or bath, is a solution of pure water, electrolytes, and salts, such as bicarbonate and sodium. Diffusion is the movement of a substance from an area of high concentration to an area of low concentration. So diffusion happens in liquids and gases because their particles move randomly from place to place. Diffusion is an important process for living things. It is how substances move in and out of the cells. Exsanguination, extensive blood loss due to internal or external hemorrhage. Hemodialysis is a procedure where a dialysis machine and a special filter called an artificial kidney or dialyzer are used to clean your blood. Hemodialysis helps control blood pressure and balance important minerals such as potassium, sodium, and calcium in your blood. Osmosis. This is when the fluid moves from areas of high water concentration to lower water concentration across a semi-permeable membrane until equilibrium. Peritoneal cavity is a potential space between the parietal and visceral peritoneum. It normally contains only a thin film of peritoneal fluid, which consists of water, electrolytes, leukocytes, and antibodies. Peritoneal dialysis is a way to remove waste products from your blood when your kidneys can't adequately do the job any longer. Tencoff catheter. The Tencoff catheter is a long, narrow tube inserted into your peritoneal cavity. The catheter is tunneled under your skin and then brought out. The place where it comes out of your skin is called the exit site. Ultrafiltration is the removal of fluid from a patient and is one of the functions of the kidneys that dialysis treatment replaces. Acid-base homeostasis is the homeostatic regulation of the pH of the body's extracellular fluid or ECF. The proper balance between the acids and bases, in example the pH in the ECF, is crucial for the normal physiology of the body and cellular metabolism. Bicarbonate. Bicarbonate is also known as HCO3, is a byproduct of your body's metabolism. Your blood brings bicarbonate to your lungs and then it is exhaled as carbon dioxide. Blood pH, the acidity or alkalinity of the blood. So the normal blood pH range is 7.35 to 7.45. Hypoxemia is a condition where not enough oxygen makes it to the cells and tissues in the body. Some of the most common causes of hypoxemia include heart conditions, including heart defects, lung conditions such as asthma, emphysema, and bronchitis. Metabolic acidosis. So this happens when a problem in your cells throws off the chemical balance in your blood, making it more acidic. This is a serious electrolyte disorder characterized by an imbalance in the body's acid-base balance. Metabolic acidosis has three main root causes: increased acid production, loss of bicarbonate, and a reduced ability of the kidneys to excrete excess acids. Metabolic alkalosis is a condition that occurs when your blood becomes overly alkaline. The pH of tissue is elevated beyond the normal range of 7.35 to 7.45. This is a result of decreased hydrogen ion concentration, leading to increased bicarbonate, or alternatively a direct result of increased bicarbonate concentration. Oxygen saturation measures the percentage of oxyhemoglobin, oxygen-bound hemoglobin in the blood, and it is represented as arterial oxygen saturation (SaO2) and the venous oxygen saturation, which is SvO2. Oxyhemoglobin, the oxygen-loaded form of hemoglobin, the predominant protein in red blood cells. Partial pressure of carbon dioxide is the measure of carbon dioxide within arterial or venous blood. Respiratory acidosis is a condition that occurs when the lungs can't remove enough of the carbon dioxide, or CO2, produced by the body. Respiratory alkalosis is a disturbance in acid and base balance due to the alveolar hyperventilation. Cystoclysis, or bladder irrigation, may be defined as the process of flushing the bladder with normal saline continuously to prevent or treat clot formation, allowing urine to flow freely and maintain IDC patency. That's it for the definition of terms. Thank you for listening.
Importance of determining total body surface area. To describe the extent of injury in the body that is affected by a burn. It is important during the initial management of people with burns for estimating fluid requirements and determining a need for transfer to a burn service. Calculating the TBSA percentage of the burn is necessary for guided fluid resuscitation. It is also important when planning future surgical intervention for people with burns. It describes an injury, determining its severity, and is a key factor in determining immediate treatment and disposition.
Hello again, everyone. My name is Gail Afra C. Larino, and I will be discussing CLO number 3 with my fellow group member, Ms. Laurete. So CLO number 3 will discuss the concepts involved in determining TBSA in fluid, peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cystoclysis. So the first will be the causes of burn. So what are some causes of burns? So there are fire, the hot liquid or steam, the electrical current, the radiation from X-rays, chemical, which are from strong acids, gasoline, or paint thinner, and sunlight or UV light from a lamp or tanning bed. Next will then be the factors influencing the severity of burns. There are multiple, such as the burn depth, the amount of skin burned, which is measured as percent of total skin, the age with the very young and very old, the most at risk, and the client's chronic illness or overall health, the part of the body burned, which can affect the function, such as with hand extremities and joints posing more problems, and if there was a presence of smoke inhalation. Next will be the phases of burn care. There are 3 phases, with the emergent phase, the intermediate phase, and the rehabilitative phase. So the duration of the emergent phase will be the onset of burn injury and lasts until the completion of fluid resuscitation or a period of about the first 24 hours since the occurrence of the burn. Next will then be the intermediate phase, which begins about 48 to 72 hours following the burn injury. And lastly, the rehabilitative phase, which begins with closure of the burn and ends when the client has reached the optimal level of functioning, or OLA. Next is the classification of burns according to the burn depth and the extent of body surface area injuries. So there are 3 degrees of burns we'll talk about today. There will be the 1st degree burn, the 2nd degree burn, and the 3rd degree burn. So the 1st degree burn, or the superficial partial thickness, has the burn depth with the epidermis and possibly a portion of the dermis. So in this diagram here, you can see that the superficial burn has only affected majority of the epidermis. Next is the 2nd degree burn, or the deep partial thickness burn, with the burn depth of the epidermis, the upper dermis, and portions of the deeper dermis. So in this diagram, you can see that the entire epidermis has been affected, with part of the dermis affected as well in this partial thickness burn. Next is the 3rd degree burn, or full thickness burn, with the burn depth of the epidermis, the dermis, and usually extends into the subcutaneous tissue, including connective tissue, muscle, and bone. So in this diagram, for the full thickness burn, you can see that the epidermis, dermis, and subcutaneous all have been affected by the burn. So the extent of body surface area injuries for the 1st degree burn is that the skin appears red but blanches when with pressure. Blisters may or not be present, with tingling and increased skin sensitivity. So for the 1st degree burn, pain is relieved by application of cool water or lotions containing aloe. Next is the 2nd degree burn, with blisters, with weeping and edema. So the pain for the 2nd degree burn and the skin sensitivity has increased and will increase with exposure to air. Next will then be the 3rd degree burn, which will appear as dry, pale white, edematous, leathery, or charred, and may be pain-free due to the destruction of the nerve endings. So next, we will talk about the various methods and formulas used to determine the TBSA injured. So the first one is the rule of nines. The listeners this should not be new to you, as we have discussed the rule of nines previously in previous years. So the rule of 9 assigns percentage of 9 to major body surfaces. The breakdown is as follows. The hand will be 9%, the anterior trunk will be 18%, and it will be divided into the upper trunk and the lower trunk, with it being respectively 9% each, but totaling for 18% for the entire anterior trunk. The posterior trunk will then also be 18%, with it being divided also as an upper posterior trunk or lower posterior trunk, but still totaling into 18%. So the left arm will be 9% and the right arm will be 9%. So the front of the arm will be 4.5 or 4.5%, and the back of the arm will be also 4.5 or 4.5% for both arms, and will total 9% each arms respectively. Next will then be the left leg as a 9%, the right leg as 9%, and lastly the perineum as 1%. Next will then be the Lund and Browder method. So this method is more precise than the rule of 9 method, since it takes into account the anatomical parts, especially the head and legs, and changes with growth. So the special charts divide the body into very small parts and provide for an estimate of the proportion of TBSA burns. The Lund and Browder method is usually used to estimate TBSA in children. So this method is mainly for children. This is the diagram. As you can see, there is age, based on age and the area and the region. Next will be the palm method, and the palm method is the percentage affected by scattered burns may best be calculated using the palm method. So the size of the client's palm represents approximately 1% of TBSA. So as you can see in this picture here, that an entire palm will be considered as 1%. So next is computing for fluid replacement. So 15 to 20% of surface body area in adults and over 10% in children warrant a formal resuscitation. With that, peripheral IV access may be initially obtained, but larger burns are recommended to use the central venous access. And the solution used for burns is the lactated Ringer's solution, as its pH and osmolality is close to the human plasma. So for the formulas today, we will be talking about two formulas, and these formulas will calculate the fluid needed in the first 24 hours post-burn. So the starting point is the time of injury, not the time of arrival to treatment facilities. So make sure to remember that the starting point is when the injury occurred. So the first 8 hours, we will administer the first half of the solution, and then the next 16 hours, we will administer the other half of the solution. So the first is the modified Brooke formula, which is the fluid resuscitation for adults within 24 hours. So for the next 16 hours, we will administer the other half of the solution. As a warning, despite the formula suggesting cutting the fluid rate in half at 8 hours, the fluid rate should be gradually reduced throughout the resuscitation to maintain the targeted urine output. So do not follow the second part of the formula that says to reduce the rate at 8 hours, and we should adjust the rate based on the urine output. So next will be the modified Brooke formula. So the modified Brooke formula is for the fluid resuscitation for adults within 24 hours post-thermal or chemical burns. The formula for the modified Brooke formula is the 2 ml lactated Ringer's solution multiplied by the patient's weight in kilograms, which is then multiplied by the percent TBSA in second, third, and fourth degree burns. So I hope everyone has a paper, pencil, and calculator as I go do the example, so you can do the computations along with me. So the example will be a 60 kilogram victim has an injury with 50% of his TBSA. So we will compute for the amount of fluid to be infused per hour. So with the formula, we have the 2 ml lactated Ringer solution multiplied by the patient's weight, which is 60 kilograms, multiplied by the percent TBSA, which is 50%. So 2 times 60 times 50 will equal 6,000 ml. So in order to determine the amount in the first 8 hours, we will divide the 6,000 ml by 2. So 6,000 divided by 2 will then be 3,000 ml. This is the amount of fluid to be given in the first 8 hours. So if you are trying to determine the amount of fluid to be given for the first 8 hours per hour, you will then divide the 3,000 ml by 8 hours, which will total 375 ml per hour. So this is the amount of fluid to be infused per hour within the first 8 hours. Next, if you're trying to determine the overall ml for the 16 hours, you will just divide the 3000 ml by 16 hours. So 300 ml divided by 16 hours will then be 187.5 ml per hour. This is the amount given for the next 16 hours. So next, don't put away your materials yet, as we will go about the Parkland formula. So the Parkland formula is for adults with electrical burns. So the formula for the Parkland formula is that it will be similar to the modified Brooke formula, though the ml is 4 mLs rather than 2 mL. So the formula is 4 ml lactated ringer solution multiplied by the patient's weight in kilograms, which is then multiplied by the percent TBSA for second, third, and fourth degree burns. So with your materials, go along with me as we do the example. So the example is a 50 kilogram victim has an injury with 25% of her TBSA. So we will compute for the amount of fluid to be infused per hour. With the Parkland formula, we will have 4 ml of the solution multiplied by the patient's weight, which is 50 kilograms, which is then multiplied by the percentage of TBSA, which is 25%. So 4 times 50 times 25 will equal to 5,000 ml. So the 5,000, if you want to determine the fluid for the first 8 hours, you will then divide the 5,000 by 2, equaling to 2,500 ml in the first 8 hours. If you're trying to determine the ml per hour in the first 8 hours, you will then divide the 2,500 ml by 8 hours, which results with 312.5 ml per hour in the first 8 hours. And if you're trying to determine the ml per hour for the next 16 hours, you will divide the 2,500 ml by 16 hours. So 2,500 ml divided by 16 hours will result with 156.25 ml per hour in the next 16 hours. And so that will be the end of my reporting. Next will then be my group member, Miss Laurete. Thank you, guys.
Good day, I am Dana Jean Laureta and I will be discussing peritoneal dialysis and hemodialysis. Under these are their advantages and disadvantages, therapeutic effect, complication, compare the different vascular access with their description, lifespan, advantages and disadvantages. For the advantages of peritoneal dialysis, first, it is easily managed at home because you don't need to go to a hospital or a dialysis center, as the procedure merely requires you to do simple steps of connecting or disconnecting the dialysis solution bag into the catheter and drain the solution once it is done. Second, it allows more independence and mobility because you will learn how to do your treatment at home according to your schedule, as long as you do it as it is required and it enables you to move around without needing to worry about the disconnection. Third, it has few hemodynamic complications because, unlike hemodialysis, the catheter is connected to the lining of a belly or a peritoneal membrane rather than directly to a blood vessel. For the disadvantages, first, it is expensive. Second, it must be done every day because, unlike in hemodialysis, peritoneal dialysis is done more frequently as its process of exchange is natural and slow. Third, it is slower than hemodialysis. The process of peritoneal dialysis is slower as there is no machine that will facilitate the flow, but merely a process or a natural process called exchange through the use of combination and the lining of the peritoneal membrane or the abdominal cavity and the solution. And fourth, the risk for peritonitis. You're at risk of developing peritonitis. It is an infection of the thin membrane that lines your abdomen because bacteria may enter the body through open ends of the peritoneal dialysis catheter during exchanges. For the advantages of hemodialysis, first, more efficient clearance. Second, short time needed for treatment because the procedure in a dialysis center usually involves using a dialysis machine 3 times a week, with each session usually lasting about 4 hours. For the disadvantages, first, the patient has limited independence and mobility because since the elimination of waste is done by a machine, you will have to go to a hospital or a dialysis center on a set schedule. Second, more expensive. Both hemodialysis and peritoneal dialysis are expensive. However, hemodialysis requires a machine as an artificial kidney which also needs an expert in handling them and maintaining it. Third, risk for bloodstream infection. For the therapeutic effect, it gives better quality of life, increased well-being, reduced symptoms and less cramping, headaches and shortness of breath, improved appetite, sleeping patterns, energy level and ability to concentrate. Options on peritoneal dialysis and hemodialysis. First, on peritoneal dialysis is infection. An infection of the abdominal lining or peritonitis is a common complication of peritoneal dialysis. It can also develop at the site where the catheter is inserted to carry the cleansing fluid or dialysate into and out of your abdomen. Second is peritonitis. It is the most common serious complication of peritoneal dialysis. The first sign of peritonitis is cloudy dialysate drainage fluid. Third is weight gain. Since dialysate contains sugar, absorbing some of the dialysate might cause you to take in hundreds of extra calories daily, leading to weight gain. Fourth is hernia. Holding fluid in your abdomen for long periods may strain your muscles. Fifth is hyperglycemia. For the complications on hemodialysis, first is anemia. Failing kidneys reduce the production of hormone called erythropoietin, which stimulates the formation of red blood cells. Second is the bone diseases. If your damaged kidneys are no longer able to process vitamin D, which helps you absorb calcium, your bones may weaken. Third is access site complications. Potentially dangerous complications such as infection, narrowing or ballooning of the blood vessel wall or aneurysm or blockage can impact the quality of your hemodialysis. Compare different vascular access according to its description, lifespan, advantage and disadvantages. First is AV fistula or arteriovenous fistula. It is permanent. It is an internal anastomosis of artery to a vein. It is located on the forearm and its initial use is usually 2 to 4 months or longer. The The second one is AV graft, and it is also permanent. It is a synthetic vessel tubing tunneled beneath the skin, connecting an artery and a vein. It is located on the forearm, upper arm, and inner thigh. Its initial use is usually 1 to 2 weeks. The third one is temporary, which is the hemodialysis catheter. It is a specially designed catheter with 2 or 3 lumens. 2 lumens are for blood outflow and inflow for hemodialysis. A third lumen allows venous access without accessing dialysis lumens. It is located on the subclavian vein, interjugular vein, and femoral vein. Its initial use is immediately after insertion and X-ray confirmation of placement. For the advantage of AV fistula, it can function for years, it is less expensive, the risk of clotting or infection is significantly lower, it provides good blood flow for the dialysis, increasing the effectiveness and reducing treatment time. It is also usually done on an outpatient basis under local anesthetic, allowing for a rapid and easy recovery. For its disadvantages, it may require another temporary type of access during the healing and maturation phase. It requires several weeks to months to mature before it can be used. Needles are required to access the AV fistula for hemodialysis. May not be suitable for people with small or weak veins. Most common problem with AV fistula is stenosis, the narrowing of the blood vessels, which may lead to a decrease in blood flow or formation of blood clots. And it is visible on the forearm. For the advantages of AV graft, it provides a solution for small or weak veins. It is ready for use in days to 3 to 4 weeks. Easy to implant and is usually done in an outpatient basis under local anesthetic, allowing for a rapid and easy recovery. For its disadvantages, it uses a synthetic material in the body. It tends to close more quickly than the fistula. The needle still required to access the graft. An increased risk of blood clotting, aneurysms, and infections. Repeated blood clots can block the blood flow through the graft. Does not last as long as a fistula and will probably need to be replaced eventually. For the advantage of hemodialysis catheter, easy healing on the insertion site, and it can also be used right away. For its disadvantage, there is a high risk for infection. ABG analysis. Explain the commonly reported blood gas measurement as to their normal values and clinical significance when the value increase or decrease. Normal value of pH is 7.35 to 7.45. For the partial pressure of carbon dioxide, it is 35 to 45 millimeters of mercury. For the bicarbonate, it is 22 to 26 milliequivalents per liter. For the partial pressure of oxygen, it is 80 to 100 millimeters of mercury. And for the oxygen saturation, it is 95 to 100%. A pH is a measurement of the acid content or hydrogen ions in the blood. Low pH indicates a higher concentration of hydrogen ions or acidosis, while a high pH indicates a lower concentration of hydrogen ions or alkalosis. Partial pressure of carbon dioxide is the respiratory component of the ABG or the arterial blood gas. A higher partial pressure of carbon dioxide level indicates acidosis, while a lower partial pressure of carbon dioxide level indicates alkalosis. A lower bicarbonate level indicates acidosis, while a higher bicarbonate level indicates alkalosis. For the partial pressure of oxygen, it is a measurement of the amount of oxygen dissolved in the blood. An increased partial pressure of oxygen level indicates increased oxygen in the blood, resulting to oxygen therapy. A decreased partial pressure of oxygen level indicates decreased oxygen in the blood, resulting to hypoxemia. If the level of oxygen saturation is below 90%, it is considered low, resulting in hypoxemia.
Hi guys, I'm Maria Devan, and I'll be discussing about the indications and contraindications of peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cystoclysis. Indications for patients on peritoneal dialysis. First, patients with renal failure, patients who are susceptible of the rapid fluid, electrolyte, and metabolic changes that can occur during hemodialysis, patients with diabetes, and patients with cardiovascular disease. For contraindications, we have patients with severe inflammatory bowel disease, acute active diverticulitis, abdominal abscess, and patients who are pregnant, especially on their third trimester, because uterine enlargement may negatively affect catheter function and prescribed dwell volumes. Indications for peritoneal hemodialysis include patients who are acutely ill and require short-term dialysis for days to weeks, patients with renal failure or ESRD who require long-term therapy, diabetic patients, and patients with cardiovascular disease. The diabetes dialysis diet will keep you healthy by managing your blood glucose levels and lessening the chances of other complications resulting from diabetes and kidney disease. Contraindications for hemodialysis include hypotension or a drop in blood pressure. This is a common side effect of hemodialysis, particularly if you have diabetes. You also have shock and anemia. Anemia means not having enough red blood cells in your blood, which is also a common complication of kidney failure. Arrhythmia, heart insufficiency, or myocardial infarction, which can interfere with your heart's ability to pump blood to the rest of your body. Also, an advanced malignant tumor, and intracranial hemorrhage or too high intracranial pressure. Indications for ABG analysis include unexpected or inappropriate hypoxemia with an oxygen saturation of less than 95%, what we call deteriorating oxygen saturation, patients at risk for respiratory failure in order to evaluate the gas exchange in the lungs, and also breathless patients who are thought to be at risk of metabolic conditions. Contraindications include arteriovenous fistula or vascular grafts, in which case arterial vascular puncture should not be attempted, distorted anatomy at the potential puncture site from post-surgical interventions, or burns. Medium or high-dose anticoagulation therapy such as warfarin, heparin and derivatives, direct thrombin inhibitors, or factor X inhibitors, or history of clotting disorder. Also, we have an abnormal or infectious skin processes at or near puncture site. For indications of cystoclysis, we have post-genitourinary surgery. This can help by preventing blood clot formation that may cause blockage to the bladder. We also have acute urinary retention. This can help drain the urine retained in the bladder, thus relieving bladder spasm. Third, we have urinary tract infection. Medications such as antibiotics can be instilled into the catheter, where it will be then drained and help cure the infection. We also have prostatic hematuria. This procedure can help prevent the formation of blood clots, therefore preventing the blockage to the bladder. For contraindications of cystoclysis, we have hypersensitivity to the solution to be used, and patients with defects in the bladder mucosa or wall, since this may cause further injury to the bladder. Next, I will explain the different principles applicable to peritoneal dialysis and hemodialysis, as well as ABG analysis and irrigating cystoclysis. For principles of hemodialysis, we have diffusion. Toxins and waste in the blood tend to move from an area of greater concentration to lesser concentration. Osmosis. Excess water is removed by osmosis, in which water moves from an area of greater solute concentration to a lesser concentration. And ultrafiltration. Ultrafiltration is water moving under higher pressure to an area of lower pressure. The force is necessary to remove fluid to achieve fluid balance. Same principles in peritoneal dialysis, we have diffusion and osmosis as well. For principles of ABG analysis and ABG test to measure blood gas tension values, arterial partial pressure of carbon dioxide, blood's pH, and arterial.
Hi, good day. I'm Harold Bernis and I will be discussing the evidence-based nursing responsibilities and guidelines in performing peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cystoclysis. Peritoneal dialysis and hemodialysis. Guidelines for peritoneal dialysis. First, strictly keep sterility. Obtain a prescribed concentration and amount of dialysate and warm them. And don't warm in a microwave oven because temperature is unpredictable. It may become too hot or too warm for the patient to handle, and don't proceed with infusion if the patient has signs and symptoms of peritonitis or infection at the insertion site. Monitor patient vital signs as prescribed. Monitor and document your patient's total fluid intake and output, and weigh patient daily. Guidelines for hemodialysis. Document patient's weight before dialysis. Take baseline vital signs. Compare client's weight before and after dialysis. Monitor vital signs every 30 minutes and report any deviations, and check for any signs of bleeding and status of the fistula. For ABG analysis. Nursing responsibilities in ABG analysis. Before, identify patient by name, explain procedure, do medical hand washing, wear gloves, prepare equipment to be used. During, palpate the radial, brachial, or femoral artery, palpate for maximum pulsation, position arm 45 to 60 degree angle, and insert needle and wait for the syringe to be filled with blood. For the after, remove needle and apply firm pressure for 5 minutes, cap the syringe needle and keep it in a container of ice. For the guidelines in ABG analysis, position the patient's arm preferably in a pillow for comfort with the wrist extended. Prepare all the equipment in the equipment tray using an aseptic non-touch technique. Palpate the radial artery in the patient's non-dominant hand. Clean the site with an alcohol wipe for 30 seconds and allow to dry before proceeding. Wash hands again. Don gloves and apron. Warn the patient that you are going to insert the needle. Once the required amount of blood has been collected, remove the needle and apply immediate firm pressure over the puncture site with some gauze. Engage the needle safety guard, and place a cap on the ABG syringe and label the sample. For irrigating cystoclysis, there is responsibilities in irrigating cystoclysis. Before, check the patient's chart, type of irrigation, whether it may be blood or catheter, purpose of the irrigation, type and amount of solution to irrigate with any pre-medication ordered and any other orders needed. Explain the procedure to the client, prepare and check the materials needed for the procedure, and position the client accordingly, supine or dorsal recumbent. During, provide for client privacy with a closed door or curtain and through draping. Expose the leg where the catheter will be taped. Perform medical hand washing. Done gloving. Clean the catheter port with an aseptic swab. Insert the port with the irrigating solution. Ensure the urine is draining freely before starting to irrigate. Regulate flow of the irrigation solution is ordered date, and maintain sterility. For the after, measure the urine output every hour. Do aftercare and do appropriate documentation. For the guidelines in irrigating cystoclysis, determine whether irrigation will be open or closed. Set up sterile irrigating supplies, maintain a sterile technique for agency protocol. Use only clearly labeled or prepared solutions for irrigation. Flush tubing prior to irrigation. Check for bladder distension, this is important. Cleanse site of entry with aseptic or disinfectant. Saline solution for infusion should be stored and infused at room temperature. The trach input and output is recommended for patients receiving CBI or continuous bladder irrigation. If an obstruction occurs in a catheter, irrigation should be shut off and manual irrigation should be performed to remove obstruction. To determine an accurate output during bladder irrigation, subtract the amount of irrigant used from the amount of drainage obtained. So that's it for evidence-based nursing guidelines and responsibilities for ABG analysis, peritoneal dialysis and hemodialysis, and irrigating cystoclysis. Thank you.
Nursing responsibilities for peritoneal dialysis and hemodialysis, ABG analysis, and irrigating cystoclysis. Nursing responsibilities before performing peritoneal dialysis and hemodialysis. So first is document vital signs including temperature, orthostatic blood pressures when lying, sitting, and standing, apical pulse, respirations, and lung sounds. Next is weigh daily or between dialysis runs as indicated. Next is note the BUN or the BUN of the patient, the serum electrolyte, creatinine, pH, and hematocrit levels prior to peritoneal dialysis and periodically during the procedure. Next is measure and record abdominal girth because increasing abdominal girth may indicate retained dialysate. X fluid volume or early peritonitis, and maintain fluid and dietary restrictions as ordered. Warm the prescribed dialysate solution to body temperature, 98.6 degrees Fahrenheit or 37 degrees Celsius, using a warm water bath or heating pad on low setting. Explain all procedures and expected sensations. Allow the client to void before the catheter insertion. Then institute abdominal skin preparation. Document the client's weight before the dialysis. Check the medications history of the patient before the procedure. Antihypertensives, sedatives, and vasodilators are prevented in order to do away with hypotensive episodes. During the procedure, monitor the level of electrolytes, obtain samples of return dialysate for culture, compare the client's weight before and after the procedure, monitor the vital signs every 30 minutes and report any deviations. Provide proper positioning for the dialysate to return from the peritoneal cavity. Place the patient in semi-Fowler's position and obtain vital signs periodically between 30 minutes. Observe proper body alignment and allow frequent position changes. Monitor for episodes of nausea and vomiting, which may occur during the procedure. And monitor for signs of bleeding by taking clotting time about 1 hour before the client comes off the machine. Observe clotting time at 30 to 90 minutes while on dialysis. Normal value is 6 to 10 minutes. Add prescribed medications to the dialysate. Prime the tubing with solution and connect it to the peritoneal catheter, taping connections securely and avoiding kinks. Instill dialysate into the abdominal cavity over a period of approximately 10 minutes. Clamp tubing and allow the dialysate to remain in the abdomen for the prescribed dwell time. Keep drainage tubing clamped at all times during installation and dwell time. During installation and dwell time, observe closely for signs of respiratory distress such as dyspnea, tachypnea, or crackles. Place in Fowler's or semi-Fowler's position and slow the rate of instillation slightly to relieve respiratory distress if it develops, and accurately record amount and type of dialysate instilled, including any added medications, dwell time, and amount and character of the drainage. The nursing responsibilities after the procedure are check the client's weight and note any difference, assess for complications, check for signs of bleeding and status of the fistula, time meals to correspond with dialysis outflow, and then teach the client and family about the procedure. Nursing responsibilities before performing ABG analysis. First is explained that arterial blood gas analysis evaluates how well the lungs are delivering the oxygen to the blood and eliminating carbon dioxide. Next is tell the patient that the test requires a blood sample. Explain to the patient who will perform the arterial puncture, when it will occur, and where the puncture site will be, if it will be in the radial, brachial, or femoral artery. Inform the patient that he may not need to restrict food and fluids, and instruct the patient to breathe normally during the test, and warn him that he may experience a brief cramping or throbbing pain at the puncture site. Nursing responsibilities during ABG analysis. First is use heparinized blood gas syringe to draw the sample. Perform an arterial puncture or draw blood from an arterial line. Eliminate air from the sample, place it on ice immediately, and then note the flow rate of oxygen therapy and method of delivery, and then note the patient's rectal temperature. After applying pressure to the puncture site for 3 to 5 minutes and when bleeding has stopped, tape a gauze pad firmly over it. If the puncture site is on the arm, don't tape the entire circumference because this may restrict circulation. And if the patient is receiving anticoagulants or has a coagulopathy, apply pressure to the puncture site longer than 5 minutes if necessary. Monitor vital signs and observe for signs of circulatory impairment. Wait for at least 20 minutes before drawing arterial blood when starting, changing or discontinuing oxygen therapy. After initiating or changing settings of mechanical ventilation or other extubation. Nursing responsibilities after. So before sending the sample to the laboratory, note on the laboratory request whether the patient was breathing room air or receiving oxygen therapy when the sample is collected. Next is prepare to transport for analysis. And then ABG syringes must be transported at the earliest to the laboratory for early analysis via cold chain. For the irrigating cystoclysis, the nursing responsibilities before is to check the doctor's order for the type or irrigation and irrigation solution needed. Confirm the client's identity and explain the procedure to the client. Make sure that the patient understands it well, and you may need to obtain informed consent. Next is gather materials and make sure that everything is in order and complete, and then perform medical hand washing. Provide privacy to the patient. Open IV tubing, then do priming. and then assess lower abdomen for bladder distension, and position the patient in dorsal recumbent or supine. And the nursing responsibilities during the procedure is drape the patient, exposing the leg where the catheter is being taped. Do gloving and cleanse the catheter injection port with an antiseptic swab. Remember to maintain sterility at all times and make sure that you are only exposing the site. Swab IDC irrigation and catheter ports with chlorhexidine swabs and allow drying. And then remove the spigot from the irrigation lumen of the catheter using sterile gauze and discard the spigot. Connect the irrigation set to the irrigation lumen of the catheter, still observing the aseptic technique. Remove the spigot or all drainage bag from the catheter lumen using sterile gauze and apply the catheter drainage bag, maintaining clean procedure. We must also ensure that there is adequate supply or irrigants nearby, as this procedure may be done continuously and as necessary, depending on the degree of the hematuria, and then ensure that regular catheter care is given. And the nursing responsibilities after are: note the amount of urine output, note the description such as urine color and degree of hematuria, as well as patient's comfort, and lastly, do aftercare.
Hello again, everyone. My name is Gail Afrasilarino, and I will now be doing the video demonstration for tracing a hemodialysis flow. So for our video demonstration for today, we will be mainly using this diagram of a virtual hemodialysis diagram. Okay, so the arterial axis is the first one. So before a hemodialysis, the patient will undergo a minor surgery in order to create an arterial axis. This will be where the dialyzer will be connected. There are three types of access possible: an arteriovenous fistula, an AV graft, and a central venous catheter. So the first one is the arteriovenous or AV fistula. So this is the best type for long-term access for a hemodialysis. This connects an artery to a vein for easier needle insertion. So as you can see in this diagram, there is the artery and the vein being connected to each other. So the AV fistula is large in diameter for fast blood flow. This is the best option for a hemodialysis, as this has the highest blood flow for dialysis. It is less likely to become infected or for a blood clot to occur, and it lasts longer than the other options. So as you can see, and these are the access for the hemodialysis. Next is then the AV graft. So the AV graft is a man-made tube to connect an artery to the vein. The AV graft is utilized when the AV fistula is not possible. So as you can see, there is a synthetic tube that connects the artery to the vein, and these two are the lines for the hemodialysis. So why is this not the best option? Well, the AV graft has a higher chance of getting an infection and for blood clots to occur. This is why the AV graft is not the best option. Next is then the central venous catheter. So as you can see here, the catheter is directly connected to the right atrium of the heart, and these are the lines for the dialysis machine. So A catheter is only for a temporary access, and it is only for emergency situations. So this is not recommended as it is closest to the heart, which if there was an infection or a blood clot to occur, this would be too close to the heart. Next is the arterial blood line. So the arterial blood line is the line where blood is coming from the patient. So the blood that has gone through this is the blood that has not gone through the dialyzer yet. So this can be considered as the dirty blood, and it can be shown here. So this is connected here. This is the arterial line. Next is the arterial heparin injection site. So it can be shown in this portion for the heparin injection site. This is used to prevent coagulation of the blood, as heparin is an anticoagulant to prevent blood clots. Okay, next will be then the plain NSS infusion set. So the infusion set can be seen in this other diagram that I have through here, the saline solution. And this is where the heparin injection site will be. So if you can see here, there are two different ports for the injection site and the saline solution. So the plain NSS saline solution is used to flush out remaining blood after the procedure. So the saline solution is only used after the dialysis has occurred. So this will be able to flush out any remaining blood and goes to prevent any blood from becoming stagnant on the line. So next will be the blood pump. So the blood pump can be shown here, and it pumps the blood and dialysis fluid along the circuit. So the blood pump circulates the blood to push out the blood. It can be seen as like the makeshift heart of the system. So next is the arterial pressure manometer. So the arterial pressure manometer or monitor can be shown here. This is the arterial pressure manometer. So this reads the arterial pressure, which represents the negative pressure of this created by the roller pump. This provides a guide on the needle placement and if there are any kinks or obstruction, as the rate here would easily change. So this keeps the flow at a right rate. So if there's any problems within the system, the pressure on the arterial pressure will then change into abnormal numbers. Next is the arterial bubble trap. So the arterial bubble trap cannot be shown here, but it will on this diagram, but it can be found around here, this area. So the arterial bubble trap is there to catch any air that is in the line to prevent any infiltration. So this is to prevent any air to go through the line in case, and which could cause for future complications. Next is then the blood capillary inflow tube. So the blood capillary inflow tube can be shown here. This is going now into the dialyzer. That is the blood capillary inflow tube. Okay, next is then the dialysate inlet. So the dialysate inlet is found here. It can be found right here, not on this top one, but rather here. So the inlet is found where the blood is coming out rather than going in. So the inlet is here, and this is where the fresh dialysate solution goes into. This draws out the waste from the blood. So this is the dialysate inlet. Next will then be now the actual dialyzer. So the dialyzer is the filter or the artificial kidney of this entire dialysis circuit. Okay, so this entire thing is the dialyzer. So the core of the dialyzer is made up of thousands of tiny mesh tubes with the blood flowing inside those tubes and the dialysate solution staying outside of the tubes. So the pores of the tube, it's not shown here, but there are multiple tubes here with thousands of pores, and the pores of the tube lets out the waste. So the waste are the metabolic toxins, the urea, and other small particles, and thus filters out of the blood. So vital substances and blood cells are held back and they do not filter out due to the size of the pores. Okay, so only the wastes are filtered out. So at the same time, excess fluid is removed from the patient's body. The transfer of metabolic toxins through the membrane into the dialysate follows the principle of diffusion. And as everyone knows, diffusion is the movement of solutes from an area of higher concentration to an area of lower concentration. Okay, so the blood has a higher concentration of wastes, and so it goes through the membrane and goes into the dialysate solution through diffusion. Additionally, ultrafiltration is done within this system by having the solutes sweep through the membrane pores along the dialysate in response to a transmembrane pressure gradient. So the principles of diffusion, osmosis, and ultrafiltration occurs within this system. Okay, next. That will now be the dialysate outlet. So following the blood coming into the and then the blood going into the tubes, and then it being filtered through diffusion, osmosis, and ultrafiltration through the dialysate solution. The solution will now go out of the dialysate outlet. So the outlet is where the used dialysate solution is pumped out and is to be discarded. So all of the dialysate solution that has the waste will then come out here on this notch here. Next is the venous bubble trap. So the venous bubble trap can be shown here, the air trap and air detector. So this is another air trap to catch any air in the system that has not been trapped from the arterial air trap, bubble trap. Okay, so this prevents any air in the system from returning to the venous limb of the fistula, as the air going into the patient's body would cause for complications. This makes sure that the blood is safe to go back into the body. So next is the venous pressure manometer. So the venous pressure manometer can be found here, and this represents the pressure represents the resistance of the blood returning to the patient via the venous needle. It may indicate the venous stenosis proximal to the needle site. So this is just monitoring if there are any abnormalities in the rate to prevent any complications during the dialysis. And so the rate should be constant. Next is the venous heparin injection site. So it cannot be shown here as well, but the venous heparin injection site is another site where you can inject the anticoagulant heparin to prevent any blood clotting. So this is just another injection site. Next is the venous bloodline. So the venous bloodline is here. This is where the clean blood goes into the patient. So before, as you can see, the red line is the arterial line, and this is where the dirty blood is, and then it goes to the dialyzer to filter out all the waste and goes out here to now go into the venous line as a clean blood. Next is then the venous access. So as you can see here, this is the venous access. So the venous access is where the filtered and clean blood will now go into the patient and into the patient's circulatory system. Okay, and that is it, you guys. Thank you. Just as a overview, this is the arterial site. The arterial access goes into the arterial line, goes to the arterial pressure manometer, which monitors the flow rate, which is then pumped by the blood pump, goes into through the line again and goes through the heparin pump. And along this line, there's also the saline solution that is gonna be used after the procedure to flush out the line, which is then goes through here through the line and goes into the dialyzer or the artificial kidney, which then filters out all the toxic wastes, the urea, other small particles, and then the dialysate inlet goes through here where the saline solution goes into, and then the saline solution with the waste then goes out to the dialysate outlet and gets discarded, and the clean blood, the filtered blood, goes out into the venous line through and through, and then there will be the venous pressure monitor, which monitors the flow rate, and then the venous bubble trap will trap any other bubbles, air bubbles that has not been detected yet, and then goes through the venous line and then into the venous access. Okay, thank you guys. Bye.